right, so let's try this again. I recorded this lecture and had the mic muted the entire time. So let's do this one more time. We're going to do Module G, Basic Restorative Care. We're going to explain the role of the nurse aide in basic restorative care and describe the processes involved in bowel and bladder training. So basic restorative care is the care provided after rehabilitation when the resident's highest possible functioning has been restored following an illness or injury. So when someone is sick, they go to rehab. They're there for, 2 weeks, 3 weeks, 6 weeks, 6 months, however long. And then from there, we then initiate basic restorative care. The goals are to maintain the function that has been restored through rehabilitation and to increase independence of the resident. Of course, the importance is to maintain and improve the abilities of the resident. We want to prevent further complications. It is aimed toward moving the resident toward independence and encourage the resident to do as much as they can, as long as they can, and as often as they can. So we want to make sure that they are doing for themselves to the best of their ability all the time. It is a team effort. We do not do this alone. It isn't the only one on the team. The doctors, nurses, restorative care specialists, physical therapists, all of those are part of this team. So we want to make sure that we are assisting the individual to accept or adapt to limitations that cannot be overcome, and to use the tools that we have provided them to become as independent as they possibly can. The nurse aide's role, because you're often the first healthcare provider to recognize signs that the resident is feeling the loss of independence, we want to make sure that that's being conveyed to the care staff. Because if the nurses don't know, if the physical therapists don't know, if the doctors don't know, then we may not know how to adjust the restorative care to make sure that we're meeting the resident's needs. You also will be the first ones who see these signs of loss of independence, the negative self-image, the anger directed toward others, the feelings of helplessness, sadness, and hopelessness. They just can't do it for themselves. I'm not the person I used to be. I'm useless now. The increased dependence on you, on the caregiver. So, they won't even attempt to participate in their care. These are things that need to be conveyed. If the resident's feeling depressed, you definitely need to let them know, because of course depression is a loss of drive to do things that that you may have once done. So we want to make sure that we convey that as well. We want to encourage the resident and support the family when there is a functional loss, either partial or complete, of a body part, and the loss of independence that these feelings can cause. So we want to make sure that we're there and let them know, this is where we are, this is the goal, this is where we want to go, and support the family in their concerns. Is this going to happen? Are we going to be able to do this? Is it really realistic that mom will be able to do this again by herself? Well, we wouldn't have set it as a goal if we didn't believe it was realistic. So we want to make sure that we do that, and we want to be sensitive to the resident's needs, because some may be embarrassed by the loss of function, so they may need more encouragement, and we wanted to get them involved in the planning of these activities. We don't want them to feel like we're telling them what they have to do. We want to show them and guide them and include them in what we're trying to help them do for themselves, and that's really what we're doing. We want them to do more for themselves. We always want to be positive and supportive. We always want to emphasize the successes and downplay the setbacks. We want to emphasize what they can do, and explain how we're going to use what they can do to overcome what they can't do. We want to explain what the activities are and how the nurse aide is going to help them gain the independence that we want them to have. We want to treat them with respect and dignity all the time. We want to allow for their expressions of feelings. Sometimes they'll get very frustrated and that will come out. Sometimes they'll throw things. We want to make sure that we're giving them what they need and allow them to express their feelings and empathize with those feelings, because they have had a loss and they very well may be dealing with grief because of that loss. And of course, we always want to praise the accomplishments, make sure they know we understand that they are doing the best they can. We want, we're just wanting them to be the best that they can be. We always want to be assist the resident have the resident assist to do as much for themselves as they can, assist them when we need to, and when they get frustrated, we always want to make sure that we are being realistic in what we're telling them that they're going to be able to do. if they lost complete control of their left leg, chances of them walking down the hallway again is pretty slim. So we don't want to tell them they're going to run. But we can tell them that you will be able to be mobile. You know, we're in the wheelchair. We can get you moving around. You can go where you want to go. You don't have to stay stuck in this bed or stuck in this room. So you want to make sure you're giving realistic goals and realistic praise. When doing restorative care, you're going to want to review the skills that will be needed to assist with restorative activities with the resident, make sure they know what to expect. We want to focus on the small tasks and accomplishments. This restorative care is kind of it's not a sprint. It's not going to be done this week or next week. It's usually going to take a while. So we focus on the small tasks and set realistic goals, realistic things that can be achieved. So it's steps. We don't want to get too far ahead of ourselves, because then that can lead to frustration if we're not getting there to the resident's desire as fast as they want to get there. We always want to inform the resident that, you know, the setbacks are going to occur and they can be expected. And when they occur, you're going to want to praise them through it. You know, it's okay. This happens. We want to continue. You want to get them to continue to work through it, and let them know that, you know, a setback today is the opportunity to improve for tomorrow. So we're not going to let this one small, you know, incident today, it's a hiccup. We'll do better. You know, we'll do more later, and, you know, we'll get it back. We'll get you there. We're cheerleaders at this point. We always want to give the resident control. We want to give them choice too. If they choose, you know, they may choose to quit. Again, you will want to encourage them to participate. You may even cajole them a little bit, maybe just try to get them two more, you know, do two more, whatever, do one more time, and then we'll be done. You know, encourage them to be the best that they can be and to give you as much as they can give you. You always want to encourage selection of appropriate clothing for whatever the activity is. You know, again, if you're going to be doing things on the floor, maybe not a skirt. Maybe you want to let them put on, you know, maybe some pants under their skirt if they want to wear a skirt. And, you know, loose fitting clothing if they're going to be doing something that's more active. And of course, you always want to show patience when working with somebody in restorative care. Patience and pacing are very important with this. If you get frustrated with them, they're going to get frustrated with themselves that much more quickly. You want to provide for rest periods and encourage independence during the activity. You can do this for yourself. You know, I'm here to help you if you need me to help you, but I know you can do this for yourself, or you can do it to this step. Obviously, encourage them to use the prescribed adaptive devices, and we'll talk about those in just a second, because we want them using them to be independent. And obviously, and consider involving the family in the care, but you don't ever want to surprise the resident with this. You want to make sure that you have their permission to involve the family, because if you bring the family in while they're in the middle of, you know, learning a new skill or relearning a skill, they may not want their family members to see them struggle. They may want to keep that private and let their family members only see the positives. They don't want them involved in what they feel like is the struggle. So always get their permission first. Don't ever just shock them. But the family being involved can help encourage them to keep going too. So it can be a good thing as well. So let's talk about the different assistive devices or devices. The prosthetic device is a replacement for a lost body part. Some examples are an implanted lens in the eye, a cochlear implant behind the ear to help those who have a specific kind of deafness, hip prosthetics, hip replacements, and of course artificial body parts such as an artificial arm or an artificial leg. The nurse aide's role is to make sure these devices are taken care of. They are expensive, so we want to make sure that they don't fall or drop. You want to make sure that when they're put down or not on the person, that they are in a safe place so they're not going to fall over or be damaged. The nurse or therapist should demonstrate application before the device is put on by the nurse aide, so there is training. But of course, when devices are first made, they usually need to be fitted and adjusted, so this would be something that somebody who's trained for this would do. Usually a prosthetician comes in, that's actually a real thing, or physical therapy will be the people that can do this. When helping the resident take on or remove their device, you're going to want to obviously observe the skin that's under the device for redness or skin breakdown, abrasions, or irritations, because sometimes there needs to be more adjustment. So if there is that, you're going to want to report it and make sure that you're doing really good skin care under there to prevent skin breakdown. And of course, you're going to want to be empathetic and able to identify with the resident if they have to use one of these devices, and understand there's a psychological toll with losing a body part that requires a prosthetic device. So you always want to make sure that you listen and provide support. An orthotic device is an artificial device that helps support and align a limb and improves function. Some examples are splints or braces, similar to what you see in the picture, and shoe inserts. Sometimes these devices are specifically fitted for a resident. Sometimes they are, like Dr. Scholl's orthotic inserts. You have different kinds you can buy, but they're not necessarily specially fitted for one person. Even if they aren't specially fitted for one person, we don't share them between residents. It's usually the resident's device, so we don't share them between people. We always want to make sure that the device is clean, that the skin under the device is in good shape. So again, you're going to want to make sure that you are doing good inspections of the skin and doing good skin care under the device. And if you notice that there is redness or rubbing, definitely let someone know. And if you're trained to do so, you can pad between the bony prominences of the device, but make sure you understand how that padding may affect the purpose of the device. So if you're not trained to do so, then let somebody who is trained do it. Supportive devices are special equipment that help a disabled or ill resident with movement. So these are things that help them with mobility. Canes, walkers, crutches, wheelchairs, motorized chairs. It's pretty self-explanatory. When a person is learning how to use these devices, you're obviously going to want to make sure safety is key and that they understand how to use the devices safely. And assistive devices are special equipment that helps a disabled or ill resident perform activities of daily living. As you know, ADLs are grooming and hygiene, feeding yourself, positioning yourself, things like that. So these assistive devices promote independence. And of course, the successful use of an adaptive device depends on the resident's attitude, acceptance of the device, motivation to use the device successfully, and support from others. So we want them to be motivated to use devices to their benefit, to become independent. And we're going to talk about a few of those. So positioning devices, assistive devices are pillows. We use pillows when we do position on the side. So pillows are positioning assistive devices. You have abduction pillows, which position the hips in proper alignment. A leg would go on each side of those and be supported so the hips would stay in proper alignment. Wedge pillows can be used for positioning. They can be put at the head of the bed or at the foot of the bed, or even used at the back to help support the person on their side. The cylindrical neck roll helps with position of head and neck. So the long cylindrical pillow helps with positioning on the side, helps support the back. The bed cradle helps with preventing the weight of the covers being on the lower limbs. A couple of reasons you may use a bed cradle would be if somebody has had a fracture and has pins in their leg, the covers can actually cause stress on those pins and can become very painful. Or if somebody has infectious cellulitis or oozing or weeping from the lower limbs and the bed sheets stick, that can be very uncomfortable to remove. So we can use a bed cradle to keep those sheets off of the lower legs. The picture shows you with the feet exposed, and this is simply to show you how the device works. If you have somebody using a bed cradle, which may be a device similar to what the picture, or it could just be a walker laid over the person's legs in the same format, we then pull the covers all the way over the feet and legs so the person's not exposed, but the bed cradle keeps those covers from actually laying on the person's skin. So that is why we use them. We don't use them to keep the covers off and keep the legs exposed to air like this picture would indicate. Eating devices are like a plate with a raised lip and a spoon, so you can scoop food on a spoon with a single hand. Sometimes, if you have two hands, you use your knife to help get food on your utensil, but the raised lip helps do that for you. The divided plate, spoon, and cup, again, it will keep the food from mixing together, but it also gives us a raised side to help get food onto a utensil. The cup has handles, as you can see, which can help somebody who may have a weak grip be able to pick up a cup and drink independently. And of course, the angled spoon can help the resident who may have limited mobility in the shoulder be able to eat or bring food to their mouth without even if they have limited range of motion, to be able to turn or rotate their shoulder. And of course, you see that spoon has a larger handle, which helps improve grip. The flexible drinking cup with a straw can help the resident drink independently. And of course, this is a different version of a curved handled spoon. The button fastener is an assistive device for dressing. It helps somebody button a shirt single-handedly. As you see, you slip the button device through, you grab the button, and you pull it through the shirt buttonhole. The zipper pull and shirt and jacket pull can help the resident put a shirt or jacket on a weak arm. So they would use this device to slide the shirt up on the weak arm and pull it over to their strong side, and then use their strong arm to slide their arm into their jacket, and that's how they get their jacket on. The sock and stocking aid is to put on socks, obviously. You wrap the sock around the aid, slide the foot into the sock, and then use a single strap in your strong arm to pull the sock into place. The long-handled shoehorn is to help get shoes on. If you don't have the ability to use two hands to help get your shoe or band wrapped around your foot or wrapped around your heel, the shoehorn can help you get the shoes on. Assistive hygiene devices, electric toothbrush. Of course, you turn it on and it provides the vibration. So somebody who may not be able to do the vigorous action of manually brushing their teeth can simply hold the toothbrush and let the electric vibrations clean the teeth while they move it all across their teeth and their mouth. The denture toothbrush has suction cups on the bottom of it, so it can be suctioned inside of a sink, so you can use it single-handedly to clean your own dentures. So it suctions, and you can use that to clean your dentures. The fingernail cleaner can be used to clean your fingernails, same reason. Again, if you only have one hand to clean your fingernails, you can suction that to the bottom of the sink and use it to scrub the fingers clean. The long-handled sponge can help clean places hard to reach, such as the back or the lower legs, so the resident can bathe themselves effectively and efficiently. This device is used by diabetics to examine their feet and heels for abrasions or sores. When you have diabetes, the sensation of touch and pain in the feet deadens over time. So there may be a sore down there. They may have stepped on something and realize that now they've got breakdown. Now they've got something that's infected down there. And this is the reason why some diabetics lose part or all of their feet. So this allows them, the mirror end, which is the square end, will allow them to inspect their feet, top and bottom, and on all sides using the mirror, so they can make sure that there aren't any sores, or if there are sores, then they can make appointments to get seen by doctors or keep an eye on them and care for them. And then the blue brush in the middle can help the diabetic resident wash their feet well, so they can get all the parts and make sure that they're cleaning away debris or dead skin, making sure they're cleaning between the toes. This is an assistive reaching tool. Of course, it helps residents pick up things that may have fallen on the floor, that may be out of reach, that may be up too high. And of course, when you have somebody using adaptive devices, regardless of what it is it prosthetic, orthotic, is it a supportive or assistive, you are going to want to make sure that you record and report everything that happened. So what was the activity that was attempted? How did the resident, what devices were used? How did the resident use them? Were they successful or not successful? Did they have an increase or decrease in their success in using these devices? What was their attitude? What was their motivation? Did they really want to work with it and do more, or did they not want to do anything at all? These things can help allow us to make changes to their schedule or their treatment plan. Maybe we need to get other people involved. And were there any changes in health evident while you were using the device? Of course, supported devices and mobility, sometimes they can fatigue the resident. So do we want to, was there a change in their breathing? Was there a change in their color? We don't want to exhaust them. We don't definitely want to put them at risk for health complications. But if they're really motivated, maybe sometimes we have to pull them back because they really want to walk, and so we need to kind of mitigate what we allow them to do, because if they exhaust themselves, if they open themselves for injury, and again, that could set them back. So we want to make sure that we record all of this. And of course, with basic restorative care, things to remember. It's sometimes maybe you think it's easier to help them, or you don't want to watch them struggle trying to do it for themselves. But the reality is we are trying to get them independent, which will help with their self-esteem and speed up their recovery. So while they may get frustrated and they may feel like they don't want to do it or they can't do it, we still are their cheerleaders, and we help them understand that it's important, and we want them to do it for themselves because we know they can be independent, and we do want that for them. So we want to make sure that we always are the cheerleader. So let's talk about bowel and bladder training. Of course, this is the measures taken to restore function of urination and defecation by the resident with the ultimate goal of urinary continence. So your book gives you the definitions of urination, defecation, continence, and incontinence. Of course, we want to maintain continence. We want to get them back to that control of bladder and bowel function. Because, of course, incontinence is embarrassing. It'll limit their lifestyle. It'll cause them to not go out or participate in different things because they're afraid they're going to be incontinent while in front of others. Or the odors may, cause them embarrassment. The odors may cause their family members to shun them, like they don't go over to visit because, the house smells, Infections can develop, of course, because if your portals of entrance are exposed to things they're not supposed to be exposed to, infections can occur. Skin breakdown can happen, which of course is another source of infection. And residents may find it very difficult to discuss that they, have bowel or bladder continence issues. So they just may isolate themselves. They don't have to tell anybody. So this is why we want to encourage them to participate, because we want them to be more independent. We want to get this back for them. So the nurse aide is a key member of bowel and bladder training, because you will be the ones that are on the front lines with this and taking care and taking the reins of making sure that the schedule is followed. Support the explanation by the doctor or the nurse for what's going on with the bowel and bladder retraining schedule. So you're going to be the one there telling them, well, this is why we're doing it, and this is what we're going to do, and you're going to remind them over and over again. You're going to want to keep an accurate record of when they went to the bathroom, what results there were, how they handled it, what's their attitude, what's their motivation, everything that you can think to make sure that everybody knows what's going on and how it's going. Is it successful? Are we working towards success? Or are we not working towards success? You're obviously going to want to answer the call lights promptly when they signal, because if the resident needs to go to the restroom, you want to make sure you get them to the restroom when they feel the urge, because that's the purpose, that's the point. And when the resident's in the restroom, we don't want to rush them. We want to give them plenty of time to empty their bowel or bladder while they're in there. So we don't want to rush them. We want to definitely give them a positive attitude. We don't scold them if there's incontinence between bladder training sessions, bowel sessions. We assist them to the bathroom whenever they request or during the scheduled times. We want to provide for privacy, because, of course, some people are shy about that, so they don't necessarily want to think someone's waiting outside the door. We want to provide for privacy. We want to provide encouragement, of course, to participate and be a part of bowel and bladder training. And we want to offer and encourage fluids, sometimes on a schedule. So if they are set to go to the bathroom at this time, then maybe an hour before we're going to offer fluids. We make sure that they have something working through the body to void out when it's time to happen, because we're not only trying to make sure that we go to the bathroom often to make sure that we reduce the risk of incontinence, but we're training the bladder and the bladder and the bowel to empty at a specific time or on a specific schedule. So that is really what the purpose of bowel and bladder training is, and you would need to explain that to them. So we want to encourage fibrous foods, fruits, vegetables, breads, and cereals, things that have, of course, fiber in them to help the bowels move. We want to encourage regular exercise, of course, because regular exercise helps keep the peristalsis in the gut moving along, and helps empty the bowel more frequently or more regularly. Teach good pericare, because we don't want an infection to cause a setback. So we always want to teach that front to back, clean to dirty, make sure that we're teaching good pericare. We want to keep the bedding clean and odor-free. Again, if there's been incontinence between sessions, we always want to make sure the bedding's clean, remove it, because we don't want the odors to linger, because we don't want them to feel embarrassed by it. So bowel and bladder training happens on a schedule. This is the general schedule. We always take them to the bathroom when they wake up, 1 hour before every meal, every 2 hours in between meals, before going to bed, and during the night as needed. Sometimes a resident may be on an every 2 hour schedule. The purpose of this is we're trying to get the body used to going to the bathroom and emptying on these specific times. So you're going to explain this to the resident. You're going to want them to participate in the bathroom schedule, even if they don't feel like it. I don't feel like I have to go to the bathroom right now. Well, let's go to the bathroom and see. Even if you only void a little bit, then we've done a good thing. This is the general schedule that everybody starts with. They may be personalized for specifics, but this is what everybody starts with. Some things you can do while they're in the restroom to help them void: running water in the sink. There's a psychological link to that. When you hear water running, the muscles in the perineal area relax, which of course makes you feel like you have to go to the bathroom. Have a resident lean forward and put pressure on the bladder. That can help the force urine out and can help that sphincter relax and help the flow of urine. Put the resident's hand in warm water. That is a physiological effect that actually releases or helps those muscles in the perineal area relax. Offer fluids to drink. Sometimes fluid in, fluid out. The body will release fluid when you drink fluid. And pouring warm water over the resident's perineum. Similar concept and similar effect as to putting your hand in warm water. When doing bowel training, enemas, laxatives, and suppositories, as well as stool softeners may be ordered to keep the stool soft. We don't want the resident to deal with constipation while we're trying to do bowel and bladder training, because again, that would be a setback for them and would be very difficult to clear. The resident may not have the energy or the strength to force out stool if they are constipated, so we want to make sure that the stool is soft enough to pass easily. Of course, enemas are the introduction of fluid into the colon to eliminate stool or feces or to stimulate bowel activity. These are ordered by physicians. This is not a nursing order, so the doctor has to order it. And of course, there are some pre-prepared enema solutions. There are some that have an enema bag and you prepare it yourself. There are tap water enemas, saline enemas, soap suds enemas. There are mineral oil enemas, milk and molasses enemas. There's a lot of different kinds, and they're used for different things. Sometimes the prepared ones are usually about 4 ounces, 120 cc's. Sometimes the enema can be up to 500 mLs of fluid. Again, those would require an enema bag, and we would make those. We would prepare those at the time that we're getting ready to administer them. The hiring facilities, we will talk to you about this in lab, and we will show you how to do an enema in lab, but we will not actually spend a whole lot of time on it because your hiring facility will train you on how to do enemas when you get hired. And if you're delegated the task of an enema and you've never done one, you need to let your nurse know that I've never done this. I need to be trained, I need direction, and I need I'm going to need some guidance on this. So don't be afraid to say I've never done it. I need you to show me. Of course, with bowel and bladder training, things to remember: it can be accomplished. You can train the bowel and bladder to empty on a schedule. You must be consistent and follow the plan always, though, which means that you really need to get your resident to participate with each bathroom session. Reporting and recording are vital to success, so we can make adjustments if we need to. And it can take up to 8 to 10 weeks, so you have to continually remotivate your person in order to get them to continue to participate in bowel and bladder training. I mean, if you think about going to the bathroom every 2 hours or so for 8 to 10 weeks, it seems like it's overwhelming and it's going to take over your life. But again, it is, what's required in order to be successful with bowel and bladder training. So that is the end of Module G.